Today we'll talk about cyanosis. We won't be talking at all about individual cyanotic heart disease, just the basic of cyanosis. So what do you mean by cyanosis? More than 5 gram of reduced hemoglobin per 100 ml, you get bluish discoloration of observable the mucosa and periphery also. This important entity, peripheral cyanosis. Peripheral cyanosis doesn't represent this thing. The blood level of absolute amount of reduced hemoglobin is not going high, but the peripheral stagnation leads to more time for the blood to remain there in contact with the cells, and cells will extract the oxygen. So periphery looks blue, but the blood level of oxygenated hemoglobin is normal. So most likely it's due to circulatory problem also. That doesn't represent a cardiac or respiratory conditions. Before you discuss about this thing, but what is the purpose of the circulatory system? Just like trees and plants which cannot move, each and every cells in your body, other than what is there inside the blood, are fixed. All of them perform some work for the body. They need something which is produced from the distant places by a cell or absorbed into the body to be delivered, like oxygen, nutrients. All of them should get rid of some of these things to be thrown out. How is it achieved? A cell in the periphery may need a material hormone produced by the pituitary thyroid, another cytokine produced by the lining endothelial cells. Everything is achieved by the connecting system, the courier system which will receive from the manufacturer and deliver to the recipient. That is achieved by the circulatory system, the pump and the pipe and the fluid which keep on moving inside the system. So the circulatory system keeps this fluid moving inside so that it connects the entire systems, entire cells in the body. So for the purpose of today's discussion, we won't be considering about the nutrients and waste. We will just consider the oxygen. Not even the carbon dioxide waste disposal I am talking. Just you consider the oxygen, how the oxygen from the atmosphere reaches a cell deep within. So for that, you just consider this one. This is a no-still atmosphere. So if there is atmospheric oxygen low, of course, when you're going very high, tall mountain, you may get the hypoxic situation due to the atmospheric oxygen level. The atmospheric pressure goes down, the proportionate oxygen also goes down. Suppose you are kept in a room where oxygen get depleted, you can develop. That's the rarest of situations. The second thing is from the nostrils up to the, I take it as the alveolar capillaries. The entire respiratory system, it is just like a handing over of a baton in a relay team. The first person's role is to take the oxygen from the atmosphere to the alveoli. Alveolar capillaries to be exact. So entire respiratory system problems can be put in one sentence. So anything goes wrong in the delivery from the upper airway problems, lower airway problems, parenchymal problems, alveolar problems, the interstitial problems, and the diffusion, the ventilation mismatch, ventilation perfusion mismatch, shunt, everything is part of the first person's role and duty. We are not again discussing this part in this session. So maybe at the end I'll discuss how to differentiate this respiratory part from the cardiac reasons for the cyanosis. Okay, now we'll come to the cyanosis. So for that, you just consider, you all read about veins and arteries and heart. The systemic capillaries, the oxygen is given to the cells, and from that point the bad blood, deoxygenated blood, is taken from the systemic capillaries to the venules to the right atrium and the right ventricle to the pulmonary arteries. Till now you had two terms, veins and arteries. We'll consider it in a different manner. I'll consider the venous side and the arterial side, the extended venous side. So the deoxygenated blood from this capillaries is reaching the alveolar capillaries for oxygenation. Oxygen is delivered. Oxygen is to be taken up at the entry, at the point of delivery of oxygen at the alveolar capillaries. So till that you consider right side. So the entire part carries the bad blood. So, and the other side, once you get the oxygen from the alveolar capillaries, the entire system on the left side is the good blood. That starts from the alveolar capillaries, pulmonary veins, left atrium, left ventricle, aorta, the branches, and to the cells. So you remodify the concept into like this. See, the tissue capillaries, bad blood moves to the RA, RV, pulmonary arteries, and it reaches the alveolar capillaries where the oxygenation is taking place. Now each molecule from here which is bad reaches here, and they'll take a lot of one molecule of oxygen, and from there it is taken, oxygenated blood is taken by a vein to LA, LV, aorta, and down. So here is the important thing. All of us know the bad blood coming from here. These are all low pressure systems. From here, you call it as an artery. You call it as pulmonary artery, but that is the worst of the blood which you can think of. The pulmonary artery is the absolute venous blood. Worst of the blood in an artery. The importance is that this is a totally low pressure system, but it's a little high pressure. It's an artery anyway. Not to the extent of the aorta, but it's a high pressure artery which carries a bad blood. Then what about this one? After oxygenation, it is taken back to the LA. So it contains the purest of the blood is at the alveolar capillaries, and from there you reach the left atrium. There can be a contamination of a deoxygenation happening from the point of entry from the alveolar capillaries to there is something called natural physiological shunting. Some of the alveolar capillaries are not going to the alveoli to take the oxygen and gets joined here. So even though you call it as a vein, it's again just like an artery. It contains pure blood in a vein. Then from the, left side atrium, left side ventricle, and to the here. So all of us just remember a story of a milk delivery person. He collects the blood from the milk from the cow. He delivers it to your house. On the way to your house, suppose he adds some water in between. So it's not the absolute good quality milk. It gets contaminated with water. The very same is the concept of your cyanosis. The oxygenated blood from the alveolar capillaries is to reach through this way to the tissues. Then it becomes, he's a very good person. He's delivering the milk which is directly collected from the cow to the consumer. Somehow, somewhere, there's a chance for adding the water. Water means contamination. So there is chance of the quality deterioration. So that is in short cyanosis, central cyanosis, due to this cardiovascular part of right to left shunt. Don't think right left shunt means it's a cardiac condition, cardiac entity of right left shunt. You know there are numbers. So you extend that possibility a little outside the heart. So where all this mixing of the water can happen to the milk. So imagine here, this is artery, pulmonary artery. Pulmonary arterial blood is deoxygenated. Suppose there is a chance for this pulmonary arterial blood to enter into the pulmonary vein without going into the oxygenated state. So he just bypasses the oxygenation point. Just like you're jumping and the queue when you're waiting for a cinema ticket. You're not going through the point, you're just bypassing 2 or 3 queues and you're reaching there. Just like that, you get an entry, you are not subjecting yourself to the squeeze of the capillaries. It just bypasses that is called pulmonary AV fistula. So that is an entity where there is desaturated blood in the systemic circulation. You won't see anything in the examination of the heart. No murmur, no sounds, no cardiomegaly, nothing. But there is a chance of our right to left shunt which is outside, which is within the lung. You won't see unless you think of that and do certain investigations. Right to left shunt which is happening at the inside the lung from the pulmonary artery to the pulmonary vein. So it bypasses the oxygenating point. The next thing can happen, commonest of the situation is the right atrium to the left atrium. Suppose all of us know for a shunt to happen, it's not enough to have a defect. The pressure relations are important. Here you need to consider one thing. You should be satisfying the pressure relation also for the blood, low quality blood to enter and mix up with the good quality blood. So how is it possible? The pressure on the right side should be higher for this entry to happen to the left side. Here it is easily you can achieve this thing because it's an artery. The pressure in the pulmonary artery is higher than the pulmonary vein. It just moves. If there is a communication, there is no need for anything. But think about the communication here, right atrium and the left atrium. When there is a hole, when there is a communication, it won't allow a right-sided desaturated blood to enter into the left atrium because the pressure on the left atrium is high. So it's not enough to have a defect. If there is a defect, it will only allow a left to right shunt. So for a right-sided desaturated blood to enter into the left atrium, there should be some mechanical obstructions at the atrium to ventricular or the ventricular to pulmonary, whatever. There's a resistance imposed on the RA, so that RA pressure is higher than the LA. So that comes in the examples of your cyanotic heart diseases. Many of them are there, where at the atrial level you can get a tricuspid atresia. Some of the situations of Epstein's anomaly, where the right atrial pressure is high and the defect is there at the atrium. So desaturated blood from there goes to the LA. It can happen in the ventricular level. The classical example is the fallow. What is happening in the fallow? The right-sided desaturated blood should be going to the lungs through the pulmonary artery for oxygenation. But what happens is pulmonary artery is stenosed. Outlet is blocked and there is a very easy path of VST. And the aorta is sitting just in front of, overriding. It's facing the RV. So everything is set for easy passage of the right-sided deoxygenated blood into the pulmonary artery. So there is a defective ventricular septal defect and aorta is sitting in front and it just accepts the desaturated blood. That's a classical example of the right-left shunt in a case of fallow. So there are innumerable examples of individual cyanotic heart diseases where this can happen. One of these criteria is like this. There is another group where the entire system is mixed up. Instead of this six type of circulation, it can be a parallel circulation, where right-sided blood again get circulated to the right, left-sided blood again gets circulated left side. There is no chance of communication. It's a parallel circulation. So there again, there is no chance for oxygenation. It's not reaching the alveoli to get oxygenated, come back and circulate. It's not possible. So basically, these are the different situations where you can happen. Here, one very important thing I said, in the atrium and ventricle, in addition to a defect, there should be a obstruction for that, so that right side the pressure is above the left side. Think about the pulmonary artery. When there is a PDA, pulmonary artery is connected to the aorta. What will happen? Normally the pressure on this side is high. It will only allow the blood, the oxygenated blood, to enter into the pulmonary artery. But there are situations where the pressure on the pulmonary arteries goes higher and higher and higher, and the circulation, the deoxygenated blood gains entry through the ductus into the pulmonary artery. The very same thing, the desaturated blood gets entry into the aortic blood without going to the pulmonary alveoli to get oxygenated. So in short, this is the basic of cyanosis. When you learn about individual heart diseases, principle is the same only. Now you come to the practical approach. How will you move forward in the analysis of the situation where you get in a clinical example of fluid discoloration? First thing, you should verify whether it's a peripheral cyanosis or a central cyanosis. So this confusion occurs only in an ICU situation where the patient is brought at circulatory abnormality, shock. The peripheral will be cold. You get all the evidences of peripheral sluggish circulation, capillary refill time poor, hypothermia, thready low volume pulse, and you are getting a desaturated peripheral blue. But where will be the distribution of fluid discoloration? The tongue, underside of the tongue, mucosa will not be blue. The distribution of the cyanosis and the evidence of the sluggish circulation are the clues. And it's not a phenomenon in the day-to-day practice when you see in the outside stable patient. One very important simple thing is to immerse the hands in water, in warm water. With the warmth, what will happen? The constricted vessels can dilate in the case if it is a peripheral circulation. What will happen? If it is a peripheral circulation, the circulation improves and the desaturation disappears. So what will happen when there is a warmth in the case of central circulation cyanosis? More and more chance of the desaturated blood to come there. So desaturation worsens if this is due to a central circulation. There is a central cyanosis. Okay. Then the next step is it due to a respiratory condition or a cardiovascular problem? So how can you differentiate a lot of hypoxic states due to upper airway foreign body, or a severe COPD situation, or severe bronchial asthma, lower airway problem, bilateral extensive pneumonia situation, significant pneumothorax, every respiratory problems which you can think of can lead to a deoxygenated state. So how do you differentiate this from the other? One thing, invariably patient will be dyspneic and the cyanosis will be proportional to dyspnea. It's not like a situation of patient walking but you see the cyanosis and clubbing in a cardiac situation. Proportionate dyspnea will be there. Then one very important thing, it will respond to your oxygen. Cardiac, the response and the proportionate rise of oxygen saturation by pulse oximetry or ABG will not happen if it is a cardiac. So response to oxygen, if there is a good response, it's most likely respiratory. Then in a child, you need not have oxygen to test this thing. One very simple thing, what happens during a cry? Crying is an improvement of the ventilation. So when the inhalation improves, the respiratory conditions, all cyanosis will improve. The cardiac condition during crying, what happens? It increases the chance of right to left shunt through the any situation. The cardiac or AV fistula, wherever, the cyanosis worsens. So that is in the day-to-day life, simplest is to observe what happens during crying. So this is how you just differentiate a respiratory and cardiac cause. Now comes your evaluation. You answered that it's not due to respiratory, it is a cardiac problem. Then there is one more step. It need not always be due to a cyanotic heart disease. There are situations where in a cyanotic heart disease, after a period of symptomatic period, develops pulmonary hypertension. Hypertension worsens and right to left shunt occurs. Classically, in a case of VSD in a young child, ASD in a little older person only, or a PDA with reversal. So all this left-right shunt with reversal is one very important situation. So we need to consider consider that entity and possibility, and should have methods to differentiate a left-right shunt now reversing. And if you rule out that also, then only comes your actual cyanotic heart disease. Cyanotic heart disease producing a cyanosis per se. You can divide in different ways of clinical approaches are there. The most people follow this method. So your clinical examination and the history will help you to differentiate basically into two groups. One is the decreased flow state, where the blood reaching the lungs is less and less of oxygenated blood is reaching back to the LA, and that is one group of decreased flow state. And the other extreme group is increased flow state. The blood circulation to the lung is normal or little high, still you get the desaturation. Why and how? I told you earlier, it's not effective saturation is not happening. The blood, desaturated blood coming to the right atrium to right ventricle is ejected out into the aorta again. There's no chance for getting into the pulmonary alveoli to get oxygenated. That is happening in a transposition of great vessels. So there are other situations where this is not happening. So different mechanisms. So you had to differentiate these two situations, decreased flow state and increased flow state. Just list the conditions where decreased flow state is responsible. Classical is the fallow and many other fallow-like states. One thing is the single ventricle with the pulmonary stenosis, double outlet right ventricle with pulmonary stenosis, transposition of great vessels with the VSD with the pulmonary stenosis. It's a pulmonary stenosis part is dominant. When the stenosis part is mild and the VSD part is more, it may behave like a VSD, left-right shunt. The other way it behaves just like a fallow. And there are other two different types of decreased flow state. One is tricuspid atresia, the other is Epstein's anomaly. Out of all these things, Epstein's anomaly is a little bit unique. There are a lot of peculiarities for the Epstein's anomaly where you may not get any of the clinical classical manifestation. They can survive up to adulthood. There may not be clinical signs of this thing. They can occasionally behave like increased flow state or a normal situation. So cyanosis may be totally missed. No clinical signs observable by the cardiac examination unless you're careful enough where you can demonstrate the cardiac chamber enlargement. So now you come to the clinical approach. So I said how to differentiate a peripheral cyanosis from the central. Next thing, how to differentiate a respiratory from the cardiac. Third thing onwards, your history is helpful. How can you differentiate an increased flow state and a decreased flow state? So we'll get recurrent respiratory infection, congestive failure. Both this indicates lungs are congested. No spells, no squatting. So no evidence of a decreased lung circulation. That means no squatting, no spell. Recurrent jaundice and congestive failure. That is a situation in which you consider the increased flow state. But there is one catch here. The very same confusion can occur when you get a pure respiratory conditions like bronchiectasis, recurrent pneumonia, recurrent respiratory infections, of course, not congestive failure. Later and later, they will develop pulmonary hypertension. They can have clubbing, they can have central cyanosis. So that may confuse you. The second situation is left-right shunt will get a history of repeated episodes and then a quiescence period and then reversal of shunt. So, three situations you may get a history of recurrent pneumonias. If you get typical history of a congestive failure, most likely you are dealing with a case of increased flow cyanotic heart disease. So, in this context, the history will be very useful because you may be missing a case of repeated severe asthma or a bronchitis or respiratory conditions. You may be missing a case of simple left-right shunt now presenting with reversal. So, congestive failure part, improving later, that sequence. One very important clue is the age of the child. Most of the situations where you get increased flow cyanotic heart diseases, unless some intervention is done, they won't survive beyond 2 years. That sort of a history, surviving beyond 2 years and later at 4 and 5 years presenting, most likely you are dealing with the other two situations, left-right shunt or respiratory NVT. So age is a very useful situation. So now you come to the decreased flow state, classical, you'll get cyanotic spell, you'll get no respiratory infection, you get squatting. So there is another confusion. There may be a situation where you get features of both. You're getting squatting, you're getting cyanotic spell, at the same time you're getting pneumonia. So which side you move? Here is the important, which point is having a weightage. If you're getting a cyanotic spell, no doubt it's a decreased flow. Pneumonia, ARI or wheezing can occur in a cyanotic heart disease patient also. So more reliable thing is to give weightage for the spell and squatting. So of course the examination also. So out of the examination, what are the things to be looked for? In a cyanotic heart disease, which are the findings which are important? The left-sided findings like blood pressure, pulse rate, pulse volume has got less value in any evaluation of cyanotic heart disease. More value is for the right-sided events like JVP analysis, the chamber enlargements. These are more important for the cyanotic heart disease. The chamber enlargement, less importance for the murmur, a little bit more importance to the heart sounds, less importance for the blood pressure and the pulse volume analysis, because very few entities you get the pulse changes. One example is maybe the absent truncus, persistent truncus, where you may get a high volume collapsing pulse. It's one of the clues. You may get a tachyarrhythmia, SVT-like situation, which may be there in a case of Epstein's anomaly. These are the rarer situations where the pulse analysis may give clue. More of the values are more for the jugular pulse wave analysis. Is the wave is a giant wave, the descent, all these things are important in the cyanotic heart disease. So what you are giving importance is which are the chambers involved, especially in a case of. So I forgot to mention about the increased flow state situation. Just I'll come to that. The increased flow state classical is one thing which present in the newborn period, TGA. The other thing is TAPVC, the total anomalous pulmonary venous drainage. The other thing is the persistent truncus. So these are all, and the double outlet right ventricle without PS, single ventricle without PS. These are all list of increased flow state. How to differentiate by the clinical examination? You check for the chamber enlargement, murmurs and the sounds. So palpation, which chambers are enlarged? All the chambers are enlarged and you get more of murmurs. That's a classical examples of endocardial cushion defect. Actually, endocardial cushion defect is categorized in the left-right shunt, in fact. A very young child, there is a mild tinge of cyanosis. And the importance is you get the all the chambers, all the right side, all the left side, because it's a combination of ASD and VSD situation. It's the in between, it's any sort of hemodynamics or shunt is possible. So all the chambers and invariably will get murmur. And classical thing about the sound is the split second sound. And you will get the MR murmur, you get the TR murmur, VSD murmur, all sort of things. Then your chamber enlargement. Is it the right-sided? Is it the left-sided? In a decreased flow state, you are differentiating between left ventricular dominant and right ventricular dominant. In decreased flow state, if you are getting a right atrial and a left ventricular enlargement, and there is not much of LV as such, that means right ventricle is not dominant. The classical is tricuspid atresia and Epstein's anomaly. And in this situation, in an Epstein's anomaly, you may not get any auscultatory findings. Second sound may be single, but only thing you get an regurgitant clicking sounds of diastole in the lower left channel wall. Name tricuspid atresia, the shunt from the right atrium to the left atrium will be silent. You'll get either a VSD murmur or a PTA murmur, continuous murmur or a systolic murmur of VSD. So in a situation of RA and LV enlargement, sideways enlargement of the heart, no pushing forward, no RV. You consider tricuspid atresia or an Epstein, where the JVP A wave will help you, where you get the murmur of continuous systolic, you may be dealing with the tricuspid atresia. There is not much of significant murmur and diastolic, even comparatively silent heart, you may be dealing with an Epstein's anomaly. About the other group, the right ventricular dominant, the classical system is the condition is the fallows. But what is it? Left ventricles are normally, there is no cardiomegaly in the normal space, and what you get is the evidence of the RV enlargement. You may not get that much of left parietal heave in a case of fallow than what you expect, because there is an effective decompression through the VSD. So RV dominant situation where the LV is not enlarged. Classical is the fallow. It can range from the very severe stenosis situation, pulmonary atresia, variants of the fallows are the different types of fallows are there. The other fallow-like things, as I said, double outlet right ventricle, single ventricle with PS, and occasionally TGV, VSD, PS. All these are fallow variants. May not be easy to but differentiate them by clinical examination. So next, you have to utilize the ECG and the X-rays also in this context. Then only you can pinpoint to. So you can come to a possibilities of a cardiac problem, out of which increase the flow and decrease the flow, different groups. Decrease flow, right-sided or left-sided. The commonest of the entities. Just few details of about the increased flow states. Classical ones, I said it is the TAP-VC. The classical finding is the second sound wide and split. It looks like an ASD with a tinge of cyanosis. And the chambers of the right-sided chambers, RA and RV are grossly enlarged. Maybe you get a gross cardiomegaly, very early symptoms. The murmur is not that predominant, unlike in you get in a left-right shunt. All the features of congestive failure, pneumonia will be presenting very early. About the persistent truncus, again you get the increased flow. Classical thing is high volume pulse and collapsing pulse. You get a cardiomegaly. One very clutching point is the diastolic murmur is happening through the aorta. It's not aorta, the persistent truncus. You'll get a leaking of the truncal valve, which is always abnormal. So I won't be continuing with the individual heart disease. So you can't pinpoint with the examination of the heart. You need ECG and X-ray also. And final confirmation, of course, is the echo, other investigations also. So I think this is enough for today.